Well, welcome everyone. We're so excited to have you here tonight for our April Sarcoidosis Awareness Month webinar. And we have the amazing Dr. Raj with us. We're so thankful he's here. Tonight, we're going to talk about sarcoidosis and oxygen. So really quickly, I want to give a quick introduction. So we are Life and Breath Foundation. We were founded by Sean Hall to support sarcoidosis patients. And that is our mission, hope and empowerment for sarcoidosis patients. And we have these webinars that we do each month. We have a support group. We have a planner that we share with patients, and different things that just are aimed at supporting patients and empowering them on this crazy journey of sarcoidosis. So tonight, yes, we have Dr. Raj Dasgupta. He is a quadruple board certified physician by the American Board of Internal Medicine, specializing in internal medicine, pulmonology, critical care, and sleep medicine. He is also an active clinical researcher with more than 20 years of experience teaching around the world. And if any of you follow Dr. Raj on his social media, you see how active he is, and how much he does. And he has just a really great ability to communicate to people that are not doctors. And he does really well at taking the jargon out of things and just explaining things to help empower people and in all the different things that he does. So thank you so much, Dr. Raj, for being here. And we're so excited to hear your presentation.
Awesome, Abby. That was an amazing intro. And hello, everyone out there. I'm like super excited to give this talk. Why? It's really practical. I think whether you have sarcoid or not sarcoid, whether it's COPD or asthma or just pulmonary fibrosis, people will enjoy this talk. And it gave me a chance to actually see the other side of medicine, because this is the practicalities of just, hey, what happens when someone says, I'm going to be on home oxygen? And what does that mean? So I got a little roadmap. I always want to be prepared. So here's my roadmap for this. I actually made a presentation. I figure let's talk about oxygen. That's the whole theme of this. It's so vital to life. So what is oxygen? And why do I need it? And you know what? Now that I'm asking that question, how does that present clinically? I'm short of breath. And how are you going to work up my shortness of breath? And then we'll get into oxygen. And I figure it's all about doing things that are practical for you. And that's going to be, what are the different types of equipment? What are the accessories? What is this thing I'm putting in my nose and this thing on my finger? So we're going to go into some of the equipment you need or don't need when we talk about home oxygen therapy. So with that being said, this is my super dorky slide. I mean, you got to go back to the basics. So what is oxygen? So I put this here not to give you palpitations from general chemistry in high school or some class in college, but oxygen, if you could close your eyes and imagine this wonderful thing called the periodic table. Okay, I lost everyone already, but trust me, there is a periodic table, and the chemical symbol for oxygen is O. What a surprise. There's a little 8 there. And just because I want to show off, you know what I mean? The 8 just stands for, hey, there are 8 little protons in the nucleus and 8 electrons circling it, and they're all nicely balanced. But you know what? When I breathe in the word oxygen, I'm not just breathing in the O. What am I breathing in is O2. So anytime you write oxygen, it's always O2, because oxygen is actually 2 oxygen atoms put together, and it forms a molecule. So during our time together, if I'm saying the word breathing in oxygen, I'm assuming it's O2. So when we talk about oxygen, O2, in the air, it makes up 21% of the air that we breathe. So I put a little chart down here to say, what is all this in the air that you're breathing? There's 3 main things in it. Number 1, tons of nitrogen. Number 2, 21% oxygen. And the last little tiny bit is carbon dioxide. And who makes all that carbon dioxide? We do. We want to blow it off. You don't want to retain carbon dioxide. That's a bad thing. But I definitely want to ask a question for anyone out there, is that who cleans up all the carbon dioxide that we spill out? And Abby, can I ask you this question? Who cleans up all the carbon dioxide in the air?
It's the plants.
Why are you so smart, Abby? Why are you Miss Smarty Pants?
Well, you know,
You know,
I'm reading
so
off of my notes you gave me. No.
so it is something called photosynthesis, where all these beautiful plants and trees being green is that, hey, they take up the carbon dioxide and they give us back oxygen. So everyone just go plant a tree and some flowers when we're done with the sock, okay? So oxygen, O2 out there, has no color or smell or taste. And one interesting fact, and you'll see why I'm talking about this, is that when you cool down oxygen, I mean like really cool it down, it turns into a liquid form. Like how cool is that? You know what I mean? So when you cool down oxygen, it turns into liquid, and there's something called liquid oxygen. And that's actually one of those options that you could kind of get when you need home oxygen therapy, but it's not commonly used. But I thought that was interesting. There's also O3, which is the ozone. So, many, many decades ago, everyone was wanting to protect the ozone. Ozone's up there in our atmosphere or stratosphere, or one of the two. And why do we need an ozone, which is O3, to protect us from all that UV radiation? So it's just amazing. It starts off with the letter O, but there's oxygen, the molecule. It turns into a liquid when it's frozen. O3 protects us from UV light. So it does a lot of stuff. But the question really becomes like, well, hey, why do we need oxygen to begin with? And forgive me on that diagram on the right. We'll just pretend it never existed. I got really dorky with this, but I gotta tell you, oxygen is so important because we always think of the big picture as my heart needs oxygen, my brain needs oxygen, and it does. Your organs need oxygen. But what's really going to be important is taking it down to the microscope, putting your eye in the microscope. So every cell in your body needs food. And what is the food for the body? The food for the body is 3 letters, and that's ATP. And you just need that to make every single process work in your body. Your heart beating, you breathing, you're walking, everything needs ATP. So how do you make this adenosine triphosphate, ATP? You need 2 things. You need to bring in some food, and that's why it's all about the diet. And when we eat food, it's all about getting some of those carbohydrates, some proteins, some fats. Then you bring them in your body, and it actually turns into ATP when you have oxygen. So if you can't bring in that oxygen, you can't make ATP, then almost every cell in your body is going to die, and you can't do the things that we do. So that's going to be the under the microscope level. But I know that someone listening here is kind of like, why did you put that there, Dr. Raj? So this little tan box is supposed to be one of a generic cell in our body. Our cells, most of the cells, not all of them, most of the cells have things called the mitochondria. And what am I showing here is all this food, like, those sugars, those carbohydrates come in, get broken down. They eventually go inside this structure called the mitochondria. And look what it combines with. Look at that oxygen up there. It combines and makes tons and tons of this ATP that helps us be who we are. It makes everything function, okay? So I'm going to take a step back away from the microscope right now and just talk about the organs to make it back to clinical again. So when you talk about, hey, how do we get oxygen in our body? And how does it get all the way to an organ or a cell? There are 3 things we need to talk about: the lungs, the heart, and do you have enough taxicabs, which we call red blood cells? So let's talk about the lungs first off. So here are your lungs on the top right, and your lungs are made of tons and tons and tons of these little balloons that we call alveoli. They're kind of like the functional part of the lung. You have thousands and millions of these things. So what happens is that when I'm breathing in oxygen from the atmosphere, which is 21% of what's made up of the air, will come into each of these little balloons, and they'll diffuse through these balloons. And what surrounds these balloons, like look at my fist, are these little spaghetti-like capillaries, which are tiny, tiny vessels where the oxygen will, I love this word, diffuse through the balloons and end up in our bloodstream. You know what I mean? So I like the top part. What do we need? We need oxygen to come from the atmosphere, 21%, into our lungs. And of course, what do we blow off? We want to blow off that carbon dioxide. So that's what our lungs are doing. So when I think about the first problem and someone's not getting enough oxygen, I'm evaluating lung disease. And you know where I'm going with this. Does sarcoid affect the lung? Definitely. Probably 90% of people. So are they damaging my little balloons called alveoli? Are they damaging the space in between the alveoli? I call that the interstitium. Or are they even damaging these capillaries that are surrounding the alveoli? Because if you're damaging any of those three areas, yeah, you're going to have trouble getting in oxygen. And trust me, you're going to feel short of breath. So what does the heart do? So the heart doesn't bring in the oxygen from the atmosphere. That's all lungs, lungs, and lungs. The heart's main job is to push the oxygen through the entire bloodstream, through our entire body, because my little toe, my kidneys, my brain, we all need oxygen. So when we talk about the heart pumping and pumping and pumping, that's called cardiac output, how much blood is going from the heart to the whole body. So that's all about oxygen delivery. So maybe in some cases, it's not a problem getting the oxygen in, but you just can't pump that oxygen out because you need someone to push all that oxygen out. But when you're pushing that oxygen throughout the body, oxygen needs a taxi cab, just can't go by itself. It kind of can, but a majority of the oxygen wants to be a passenger in a taxi cab. And what is the main taxi cab in our blood? It's right here, the red blood cells. So you can see this nice little highway coming from the heart with all these different taxi cabs. And you know what's inside these taxi cabs? There's no nucleus, there's no mitochondria. So let me go back a little bit. We don't have any of these shenanigans over here. What do we have inside these red blood cells? Absolutely nothing. They're like empty containers that just have one protein called hemoglobin. And you probably heard that before because people are always asking you the word, are you anemic? And why are you anemic? So all these are just a bunch of containers that carry what? Oxygen. Because all those cells, all those tissues need what? Oxygen. So how am I going to combine all this together? I got this cool little diagram right here. So it's really this whole human gas exchange. Atmosphere is way up here, 21% oxygen. You breathe it in, it goes into your body, it gets pumped out through the heart, it gets carried by these red blood cells going to all the organs in the body, and the organs are made of cells. We use that oxygen to make ATP. Then our waste product is always carbon dioxide and it goes out. So that was all of your first year of college biology in one shot. So anyways, but
All right. We
no, you guys are all like
the
super good
credits.
now. I told you I got into this, man. I don't know. So what happens over here? This is going to be one of my patients, right? Patient looks a little short of breath here. So everyone's going to ask me, hey, so why am I short of breath? And how are you going to relate that to sarcoid? So as a pulmonologist, when someone comes to me and says, hey, Dr. Raj, I'm short of breath, I always think of the big three. Is it a problem with the lungs? Is it a problem with the heart? Or you just don't have enough taxi cabs in your body? So then I take sarcoid and I apply to each of these organs. So does sarcoid affect the lung? We already went over this. The answer is yes. So what did I put on this side? This is the classic picture of someone who comes in who is getting a, just an x-ray for maybe a pre-employment physical or for no other reason. Then all of a sudden they're like, yeah, there is this masses around the hilum. And you're like, what? And they're like, it's cancer. And you're like, what are you talking about? Or it's TB. And you're like, no way. But you don't really have much symptoms, but you just have findings where you get a lot of fullness of big lymph nodes. It's scary. But then some people can get this over here on the right side. That's a CT scan. And wow, that's fibrosis. That's a lot of just scarring in the lung. So if you have scarring in the lung, check this out. I'm going to go back over here. So that means that this area in between these balloons and the capillaries, that's called the lung body, the interstitium. If it's all fibrosed, this is where fibrosis happens, you're not going to get oxygen into your body. So definitely it doesn't surprise me that people who have really bad sarcoid in the lungs, it's scarring the lungs, it's fibrosing the lungs, yeah, we may need to help you out with some of that supplemental oxygen on the oxygen, perspective. But yes, we are going to try to give medications to control the inflammation, to help out with the fibrosis, but that's one thing. So that's going to be lung. So what about heart? Does sarcoid affect the heart? Yeah. I'm sure everyone's yelling right now. It definitely does. And I'm sure someone's raising their hand to say, my doctor's working me up for cardiac sarcoid. And I would say the hottest topic right now in sarcoid is cardiac sarcoid because we really have new imaging and so much more data, and we know it's serious. I mean, it's the heart. So when we talk about sarcoid in the heart, what can it do? What a surprise. Sarcoid can do anything to any organ, but it could be arrhythmias. I'm sure it could slow your heart rate down. We use the word heart block. Not to be scary, it can cause sudden cardiac death. But of course, we worry about heart failure. And when the heart's not doing its thing, can it pump blood throughout the body? The answer is what? No. So you can't do this. It's not going to be shooting blood out the body. And if you're not shooting blood and oxygen out of the body, you're going to feel what? Short of breath. So of course, the minute you say, hey, I'm short of breath, doctor, they know it's not going to be the lung because the lung seems pretty good based on imaging and breathing tests. They're going to look at the heart. And what did I put here? I put probably the two most common ways that we evaluate cardiac sarcoid, and everyone's going to start raising their hand. How many has ever got a cardiac MRI? That's like the big thing right now. Or how many people see, look at Rachel, dude. Rachel's all over this, man. You know, who's got like a cardiac pet. So these are all things that we do, or we combine these two together to kind of figure out, hey, did you have sarcoid in your heart at some time? That's more like the MRI. And so, or is sarcoid actively doing something in your heart? That's kind of like the cardiac pet. So we use all these things because, I'm sure if we were talking about how do I diagnose sarcoid, we always talk about biopsy. But it's hard to diagnose cardiac sarcoid because we don't go around biopsying the heart for obvious reasons. It just sounds like not really a good idea, So we always say things like it's presumed it's going to be in the heart. But sarcoid in the heart, if it happens, boom, that could be another cause of why I'm short of breath. So then the last thing is going to be the RBCs. And of course, the question goes, can sarcoid affect your bone marrow? And the answer is, why not? It can affect almost anything. So it's not common that sarcoid affects your bone marrow. Sarcoid could definitely be in the bone marrow, but it doesn't necessarily have to cause inflammation and trouble. But in your bone marrow, you make all your cell lines, like platelets and white blood cells, and of course, red blood cells. And if you're getting active inflammation in the bone marrow, yeah, you're not going to make red blood cells. No red blood cells means no taxicabs. No taxicabs means no what? Oxygen delivery. So beyond just sarcoid going to the bone marrow and doing its thing, what else can it do? Sarcoid can cause you to have this medical word called hemolysis. So you're going to ask me, what is hemolysis? It just means that something's causing you to break the red blood cells. It's like someone damaging those taxicabs so they're not drivable. You know what I mean? So sarcoid can do a number on your red blood cells in many different ways. So how do you know you're anemic? That's the easiest of all. Hey, let me give some blood. Let me get a CBC, and let me see if you're anemic. And of course, anytime you're anemic, anemia is not a disease. It's a manifestation of an underlying disease. So what does your doctor need to do is figure out why you're anemic. And tell me if you heard this before. Just because you have a symptom doesn't mean it's sarcoid. And that's what makes sarcoid so difficult, right? Because if you're sarcoid in a woman in a reproductive age, I'm going to ask about your periods. End of story. If you're sarcoid, you're on the older side, greater than 45 nowadays, and you got blood in your stool, dude, I'm going to be, referring you to get a colonoscopy or something, So I always have to treat the underlying disease. But of course, if you have sarcoid, it should be evaluated. So this is always going to be what I call the big three of why you're short of breath. But why do you need oxygen? You need oxygen if the problem is where? In the lungs. The heart and the red blood cells are about what? Delivering the oxygen. But what brings it into your body is always going to be the lung. So that's why I wanted to explain this so you understand what's going on. So with that being said, why do I need to use home oxygen? Well, because of the fact that there is some lung involvement, whether it's going to be in the balloon sacs, whether it's going to be the capillaries surrounding the balloon sacs, or that fibrosis, scarring in the interstitium, you may need something. And that just means that that 21% oxygen in the air is having a hard time diffusing through your lungs into the bloodstreams. And if you have low oxygen levels in your body, look at these symptoms: shortness of breath, low energy, headaches, chest discomfort, and just distress. I think the worst feeling being a lung doctor is when I have a patient who's hunger for air. They're like, oh, it's just a horrible, horrible feeling, you know? And of course, depending on your underlying disease, depending how low the oxygen is going to be, can it be life-threatening? Of course. And that's why if one of my patients is already on home oxygen, you're on my 24-hour radar because you don't have a lot of reserve left in your body. So I got to make sure there's a lot of communication, whether it's with me or the people supplying the oxygen. And I really want to make sure you understand who's supplying the oxygen so you can call them and get the right equipment and therapy as safely and quickly as possible. And we'll talk about that. So when you're leaving the hospital, and I'm just to pretend you're in the hospital, well, you're always going to ask me, okay, so I need oxygen. And of course, I'm going to try to treat the underlying cause. Well, how much oxygen should I use? And, it really depends. I'll try to answer this in many different ways, but, not 10 days before your discharge, but probably a day or two before your discharge, I may do something to make you walk around and have an oxygen monitor on your finger. I would kind of figure out how much oxygen you're going to need at the time of discharge. Now, maybe you're going to get better, and at some point you won't need it at all. Maybe sometimes you will need more, but I'll give a rough estimate before you leave. And what do I prescribe? I describe a flow. So I don't go around saying this person needs 45% oxygen. No, it's not really a percent. You know what I mean? I give a flow. And what is flow? Flow is kind of a physiologic term that means volume over time. How much flow of oxygen do you need over a period of time? So I usually use 2 liters per minute. So 2 liters of oxygen are going to get sucked up per minute. So it's a lot of flow, you know what I mean? So I give a flow rate to actually kind of mimic an increased percent of oxygen. So if you go on 2 liters per minute, that's kind of like getting 28% oxygen instead of 21% oxygen. So I give a flow rate. Now that flow rate is going to change because if you're just, it's always classic. I always do rounds with my residents and my fellows who I love to death. And if the patient is just sitting there in bed doing nothing, we're like, they look great. I'm like, sure, they look great, but they haven't moved yet, So it really depends on what you're doing. So you may need to change that flow depending upon, are you going to have strenuous exercise? Are you sitting down? And you have to have a lot of changes. And one of the changes I was going to say is like buying like a shower chair. So my mom, who I love dearly, is like moving in with me, and she's older, and I always worry about the most, common thing that gets everyone when you get older, the fall. So, I'm getting like a little shower set up for the bathroom. So yeah, I'm such a big proponent of shower chairs now. So if you know somebody who's getting older, God bless it. Get them a shower chair. It's a gift that keeps on giving, dude. All right. So how do I measure my body's oxygen levels at home? So when you finally get home oxygen, we'll talk about who gives it to you. The company, and I'll say it right now, the DME company, Durable Medical Equipment Company, may give you a pulse ox or not, but if they don't, you know what I mean? I definitely will get a pulse ox. It's gonna be your best friend. And one of my things I tell my patients is that as much as possible, put a lot of, write down a lot of your oxygen levels throughout the day. In fact, one of my favorite words is called journaling. I love a good journal. And I think that you get a journal and say, during this time, during this activity, what was my pulse ox? Because when you follow up with me or your pulmonologist, whoever it's going to be, it's nice to kind of say, yeah, my oxygen was this level before going to bed or after I walked, and this is how far I walked. It really does a lot. So pulse ox is going to be one of the main things that we need in a practical sense once you have home oxygen. So when is it too low? When is my oxygen level too low? So, I'm being very broad strokes here. So in general, if you're kind of between 92 to 100%, I'm okay. I'm good with that, assuming you're, my favorite word, asymptomatic, no symptoms. But, the truth is, me or your doctor is going to say, what exactly is your goal? And I do have some people with bad COPD, chronic obstructive pulmonary disease, I mean, I like them kind of above 88 sometimes, you know what I mean? So we're going to kind of like tell you what is your goal, you know? But as a rule of thumb, you know what I mean? That, hey, if your pulse ox is below 88, and I like this word here, symptomatic, because it's a pulse ox. Maybe you have bad nail polish that day. Or maybe, you know what I mean, they couldn't read it, or maybe it fell off. I mean, I don't want anyone to panic just because the number's low, and it could be something technical. But if you give me the two words, I'm short of breath and it's low, yeah, that's a no-brainer. That's a 911. That's go to the emergency department. So, all right. So now we're gonna get some home auctions set up. What's it gonna look like? So, in fact, I don't want to like, push away responsibility, but this is all I do. I feel like my job was really super easy. I write the prescription. I do a workup. I try to treat the underlying cause the best I can. But once you need home oxygen, I write a prescription and I write down you need 2 liters or 3 liters or 4 liters. Boom, there goes my case manager. There goes my social worker. There goes my hardworking residents. That all gets taken care of. But what I really want to focus on is that your hospital will coordinate with what's called a DME company. And I'm going to say it 1,000 times, durable medical equipment. And they are the ones who are going to be your besties. They're going to be your best friend. You really have to communicate with them. And I know it's not easy. I know they're kind of hard to get a hold of, but you really have to try to. So DME companies, we'll talk about them in a second, are going to be the ones who supply your oxygen equipment and other important equipment. And the third bullet point, I hate to say it, it's their responsibility for the maintenance of the equipment that goes there and the replacement of the equipment that goes there. And why is that? Is because it happens all the time. I have so many of my patients who I love dearly, who when something happens, they just call my office. And I love my staff. They work uber hard, but there's nothing they can do because they're not the DME company. They just have to call the DME company, which they should have given you that contact. And the DME company has their own respiratory therapist or own team that's supposed to do all these things in theory. So what is this DME company I'm talking about? So I just want to read this off to you. It's a company that provides medical devices and equipment for home use prescribed by me to help you with medical conditions and disabilities. So what are some things that DME company will give you? Wheelchairs, walkers, hospital beds, oxygen equipment, CPAP machines. So many of you know I'm a sleep doctor too, so they'll get BiPAP and CPAP and all those things. Those use nebulizers, the nebulized devices given by a DME company. So that's what they do. So where exactly is this oxygen equipment coming from? So your provider, whoever it is, your primary care, me, can help you choose a DME company. Or if you got some pretty awesome insurance, you can choose it yourself. But the truth is that insurance companies already dictate what DME company, oxygen company you must use. You know what I mean? So it really comes down to your insurance. It always comes down to insurance. And nowadays, I do a lot of underserved things. You know what I mean? It's really frustrating when people who really need oxygen, even though they'll always get it, it's just not the easiest. And it's so important. It gets frustrating that there's so many hoops that my patients need to jump through. So who'll pay for this? You know, I mean, I wanted to put some practical things in here. So in theory, once again, most insurance policies will cover it if it's deemed necessary. So that's my job to do the documentation of how it's necessary. So I really wanted to say, how do I prove it's necessary? So according to guidelines and policy, there's 2 tests I could either do to see if you qualify for home oxygen. One is called a pulse ox. So this is called a pulse oximetry. You put it on your finger. If your pulse ox is below 89%, whether it's when you're exercising or at rest or at sleep, boom, you qualify. Or you could use something called an arterial blood gas. That's when I take a needle and I put it in the artery and no one likes it. Has anyone had an ABG before? Anyone want to give a little yes, maybe? ABG? Was it
Yep,
pleasant?
you got people.
Did anyone enjoy their ABG? I feel really bad doing it, But I take that needle, I put it in the artery, it hurts, no one likes me, and it tells me how much oxygen is really in that blood itself. And there's cutoffs where if you're P little AO2, that's partial pressure of arterial oxygen, is below a certain number, which is 60, then you qualify for it. So these are the ways that I have to see if you qualify for home oxygen. So, how do you choose the right equipment for me? So it's supposed to be a group decision in theory. So it's your healthcare provider, which is me. It's you who's listening to this today and the DME company. We all should work together, which we don't, but in theory we do, and we need to talk about your lifestyle, your activities, and how much oxygen do you need. And really the goal is to get you the right equipment so you could actually enjoy. I know that's a very strong, happy word, but I really want people to continue what they're doing. I know everyone says quality of life all the time, it's overused, but I really want you to have the great quality of life when you're in oxygen. It's supposed to still make you happy, not make you go the other way, which is depressed, that just cascades into many things. So, what are some things that you should consider when you choose your equipment? So I think the first thing is the amount of oxygen that I prescribed. So that's going to be really important because if you're on a high flow of oxygen, you're really going to bleed through the oxygen very quick. You're going to deplete it. So if you're like in a tank, when you're walking through a tank and your oxygen requirements are only a little bit, like 2 liters per minute, that tank will go a long way. But let's say you're on a higher flow, like 4 liters or 6 liters. Wow, you're really going to go through those tanks. So, is there going to be the practicalities? Are you going to carry these big tanks or multiple tanks? If I give you a small device that makes the oxygen, can it make the oxygen fast enough because your flow is so high? So it really comes down to how much oxygen are you going to be on, And, what is your goal? Is the goal to like get you 2-3 hours away and to go shopping in the mall? So definitely how long and how far you travel goes into that. What activities do you want to do? And of course, I want you to do everything, but the more strenuous the activity, the more backup oxygen you need possibly. Then, size, strength, endurance. I mean, it makes me choose what type of equipment are going to be practical for you. Other things, the layout of your home. I don't want to be nosy, but is it a 2-story home? What does the bathroom look like? You know what I mean? All these things are going to be factoring in. When we choose the device, you know what I mean? Are you a nasal breather? Are you a mouth breather? And this very generic word, dexterity. And, that's dexterity is so important as we get older. And that's why my mom gets a little shower chair now, because it's, not only in one of my patients with oxygen, you have to wheel a tank, carry a concentrator. It's hard. And of course, we do want to incorporate your personal preferences when we pick the device. So let's talk about this. What types of equipment are available for you? So what do you get to choose from? So there are 3 main types of equipment. One is called compressed gas. The other is a portable oxygen concentrator. And the last is a liquid oxygen, but I put a little asterisk there. So compressed gas is classically, like you see here on the top right, are tanks. So when you talk about compressed gas, yeah, sure, there's no electricity involved, but it's a tank. How big of a tank are you going to get? Is it an emergency tank? How fast is the liter flow? But these are compressed gas. An oxygen concentrator, we'll talk more about that in a couple slides, but this is going to be your main device, that you're going to have a main oxygen making device in your home. What does the concentrator do? It sucks the air from right here, it's 21%, and it concentrates the oxygen. So you have pure 100% oxygen coming out. So there is an oxygen concentrator that could be portable too. And liquid oxygen, it just sounds cool, something from like Terminator 2 or something, But see, Abby liked that one. Not even got the Terminator 2 joke, But when we talk about liquid oxygen, what did I say is that when you cool oxygen down, it turns into a liquid. And then the reason why they don't use it, because you need to have a home tank that it's not easy to get that liquid oxygen to go in there. They have to deliver it every so often. And then you have to refill portable tanks with it. And it's tough. And in certain cities like California, it just doesn't make a lot of sense to have portable liquid oxygen and liquid oxygen devices. So it's very uncommon. Its main claim to fame is that people who require very high flows of oxygen, liquid oxygen lasts a very long time, and they give you a very high flow, but just no one uses it. You know what I mean? So it's there, but it's just really hard. And most insurance companies do not cover liquid oxygen. So this is what you get. You get stationary oxygen. So this is the primary source. This is a portable oxygen concentrator. This is a stationary oxygen concentrator, and it usually goes around 5-liter flow, and sometimes a bigger unit goes 10 liters flow. So you leave it at one central location in the house, and you get really long cord, like a long nasal cannula, long cord that connects it around 50 feet to anywhere in the house, which you got to be careful because it's a long cord. You could trip, the cord gets tethered. But yes, so when you get this home oxygen concentrator, you can't see it well, but here in the middle is going to be your flow rate. So you're going to be taught to how do you adjust the flow rate? Do you put at 2 liters or 3 liters or 4 liters? You could connect this to a humidifying device that we could talk about, but you can see that there's a cable here, which there's tubing, which is like 50-foot cable that'll eventually lead into a nasal cannula per se in most cases, but you need to have electricity. So if there is a power outage, then yeah, it's not going to work. And that's why it's so important to have backup tanks in your house if the power ever goes out. So this is the nasal cannula, and it's connected to a 50-foot tubing. So the nasal cannula is kind of short, but the tubing is 50-foot long. So when we talk about, the nasal cannula, I'll say this now, you can wash it, you know what I mean? But it's really preferred that your DME company give you a new nasal cannula every 2 to 4 weeks. I don't want to throw any of these DME companies under the bus because they're kind of cheap, but you should get a new one every 2 to 4 weeks, but you can definitely wash it at least every so many days with soap and water, And I put this here because when I give this lecture to many people, people always ask, what's the best way to clean this and do that? Nothing beats following the instructions from the DME company or the instructions from the manufacturer. Those instructions are the way to go. And for nasal cannula, usually I pick like warm soapy water. That's what I do, just if you're interested. So these are the tanks. This is called compressed oxygen. So when you get tanks like this, they do not require electricity, and you definitely could get tanks that are small enough to travel. But once again, depending on how fast the flow is, you could really go through that tank pretty quick. But you should definitely need tanks as a backup if your home oxygen concentrator doesn't work. And you should keep one in the car sometimes. It's definitely a very important backup. And we'll go put one slide there to show you how do you use the tank. I thought that would be very important. And ba-ba, there it is. So once you get these tanks, well, what are you going to do? There's something called a regulator. And then you could see that in this picture on the right, you need to know how to put on this regulator. Maybe that's where YouTube could be helpful, But what you do is you connect this because how could you adjust the flow rate unless you have a regulator? So each tank has a regulator to tell you what the flow rate is going to be. And more important, when you get these tanks, you get this thing called the wrench. And I'm sure someone who's listening who has home oxygen, don't lose the wrench or you can't turn on the oxygen. So once you connect it to the tank, you use the wrench to turn on the oxygen to get you the appropriate liter flow. So the regulator and the wrench are the two most important things you don't want to lose. So it's kind of small, so I apologize, but this is kind of a summary of the 3 main systems. On the top, I put the ambulatory, which is the walking outside the house component. And then here is the stationary, which means the at-home component. So if you get compressed gas, that's going to be like those tanks compressed. So at home, it's stationary, you get the concentrator, that little box. And when you want to go outside, your DME company will give you one of 2 things. They'll give you a bunch of tanks to take outside, or they may give you one of these really cool home oxygen concentrators where you could fill up the tanks yourself. It really depends on your DME company. Liquid oxygen, whatever. It's rare to get it. I just said that, but the concept's the same. There's a stationary component at home where they fill the liquid oxygen up. And then when you go outside, you have these tiny refillable tanks, and who refills the oxygen? You get it from the home component. Then last but not least is portable oxygen concentrator, which these are going to be just a device, there's not tanks, it's a small device that makes the oxygen. It's like these big home components, but it's tiny. But remember, they're making the oxygen by what? Sucking in the atmosphere and concentrating the oxygen and giving it to you. But it only can do that at a certain rate. So if you're on a very high flow rate, 6-8 liters per minute, there's no way that little device can do it. So if you're on a lower rate, like 2 liters per minute, 3 liters per minute, that might be something to look into and ask your DME company if you qualify for a portable oxygen concentrator. Not all of them will give it to you. And with that being said, let me show you some pics. So oxygen conserving device. So some of you may say, what is he talking about? So when you're having those portable oxygen walking around concentrators, have you ever been next to someone with oxygen and every time they breathe in, you hear this noise?
Mm-hmm.
Have you guys heard that before? You want to give me a little thumbs up if you heard the little before?
Yep.
So when you hear that little noise, it means if you look at this diagram that you get a pulsed flow. So anytime we talk about most of these devices right here, it's continuous flow like this diagram. Zoom, zoom, it goes in and it bleeds the tank. So what usually happens if you're on this portable oxygen concentrator, they would do what's called a conserving device that will only trigger when you breathe, so it conserves the oxygen in the tank. And I gotta tell you, if you require a lot of oxygen, your body is not going to like it if it's only getting. So you really should test if you qualify for that, because for some people it makes them more short of breath. But if you could do an oxygen conserving, that's a good way to get more time away from home when you use a portable tank. So what are going to be some of the accessories you should at least ask about when we talk about home oxygen therapy? I love this. It's called, and I like this word, reservoir. I love asking about the reservoir tubing. So what is a reservoir? I'll show it to you in 1 second, then we'll go back. Or let me show it to you now. Boom. So if you're wearing your nasal cannula, sometimes your DME company may order this little pendant. I don't know if anyone has ever seen that before. Or you can get this thing called the mustache over here. And these two things are reservoir. What are they going to hold? Oxygen. So when you breathe in, you breathe in oxygen, but when you breathe out, this is when this reservoir is going to fill up with oxygen. It fills up during exhalation. So during the next inhalation, you get kind of a bolus of oxygen. So it actually will let you get more oxygen at a lower flow rate. And that's why many of us will say, hey, maybe we could keep it at 2 liters per minute if they're wearing a pendant or they have a cannula. So one thing to ask is thinking about, hey, is there a reservoir tubing? You know what I mean? And we call that brand name oxymizer. Do you have an oxymizer? Of course, humidification is always nice because when you have stuff in your nose, it dries it out. So ask about humidification. And then just practically, if we're talking about more about, carrying and portability, ask about carrying cases and cards. You'll be surprised what your DME company has or doesn't have. So I wanted to put like a group picture here of all the different things that we have. I have nasal cannula on the top left. Sometimes if you need more oxygen, more flow, we do a simple face mask. If you're in the hospital, you may use a face tent. But this is the oxymizer that I showed right here to help have that reservoir of oxygen. One of these medical words is a Venturi mask, where I can really control the flow, the percent of oxygen, this orange device. Like I said, flow is just 2 liters, 4 liters, 6 liters. But this makes me be a little more accurate with the percent of oxygen. You don't want to be on this. That means you're seeing me in the ICU. That's called a 100% non-rebreather. That's more of an in-hospital thing. High flow nasal cannula. What makes it high flow is that anytime you do regular nasal cannula, we're talking 2 liters per minute, 3-4 liters per minute. This high flow, we're talking 20, 30, 40, 60 liters per minute. This is not something you do at home. This is something when you're not doing well in the hospital. And these are going to be, CPAP, BiPAP. Many of you will kind of recognize these. If you have obstructive sleep apnea, they're the same types of devices. If you're someone who has obstructive sleep apnea, you still need to use it. We also use these masks in the hospital when you're not doing very from a breathing standpoint. But I just wanted to show you what it is. But remember, CPAP, BiPAP don't give you oxygen. It's just pressured air. If you need oxygen, we need to run it through the CPAP machine and through the BiPAP machine. So as we get closer to the end, I just want to do a couple things. Number one, tips to maintain your equipment. So I can't say this enough. Please follow the instructions when it comes to cleaning. They know best, not me. The nasal cannula should be changed every 2 to 4 weeks, but you should wash it in between. The long 50-foot tubing, I don't know how anyone could wash a 50-foot tubing. That sounds weird, but it should be changed monthly. So be sure to ask your DME company about it. If you're on a face mask, which is something like a simple face mask, that should be washed, and cleaned with like a warm soapy water, like twice weekly. If you have an oxygen concentrator, such as something like this over here, they have filters. And I don't know if your DME company should tell you about it, but you need to change those filters. So something to ask about is, hey, are you giving me filters? Or should I clean them? If you're going to clean them, some of my patients do with warm soapy water, but you want to ask about it. You know what I mean? And if you use a humidification device, I know everyone cheats, but you need to use distilled water. I love my patients that are like, yeah, I just turned the tap on, but distilled water is not for your health, so you won't damage the machine. And it is kind of painful once it damages the machine. So it really should be distilled water. Then this is my personal preference. I want everyone listening today to have a home oxygen plan. And this should be discussed with your prescribing doctor. If you're sleeping, what should be your liter flow? If you're doing a low intensity things like you're watching me or you're eating, then maybe you'll be on like a 2-liter flow. But hey, if you're climbing stairs, chores, walking, how high should I put that liter flow to? So it's good to have a home oxygen plan. And once again, hey, when is it an emergency? If my oxygen is below 88 and symptomatic, who should I call? And I can't say this enough. I mean, you really, really, really need to be proactive with your DME company. Have their number right next to you, your contact person. You need to really, really go out of your way to be proactive in that. So I like this, pulmonary rehab. I don't know if any of you out there have been sent to pulmonary rehab before, but they're just the most awesome people in the whole world. You know what I mean? I sent my dad there when he was having some lung issues, and you're really around other people who are kind of dealing with the same respiratory things. They really train you on how to breathe. My COPD patients, they do this pursed lip breathing. They tell them how to take breaks, not to panic. And it's just supervised exercise. And that's what you need. You still need to exercise. So pulmonary rehab is a great place to help out with that transition of being on oxygen, to realize you're not alone and people are going to help you. So please ask your doctor about pulmonary rehab. And of course, does your insurance cover it? And how many are they going to cover? And where's the closest pulmonary rehab? But please, there's no harm in at least asking about it. And then, the summary. So I put the 4 most important points here of my talk today. Number one, if you say I'm short of breath, is it the heart? Is it the lungs? Are you anemic? Or for me lately, I'm getting a little out of shape. I need to go to the gym a little bit more. So you never know. So you always want to treat the underlying cause, and oxygen is just giving you oxygen, but we always want to treat the underlying cause. If you think you need oxygen, ask me. And what could I do? I could do a pulse ox, ABG, walking study, maybe a 6-minute walk test. There's ways we could evaluate it, And then the third bullet point is being involved and proactive. You know what I mean? Nothing's going to be you knowing who to contact and when to contact. So that's my biggest pearl there. And of course, be prepared and have a plan. What happens at rest? What happens in emergency? You don't want to come to think about these things on the last moment. And with that being said, look, I gotta tell you, Abigail, that time just flew by, homie. Like, what happened?
Yep.
You know what I mean? But
Yep.
let's give me my little closer, and I'll do some questions.
Yep.
I just really hope you enjoyed this. I really didn't think I was going to talk this much, but I enjoy it, and I hope you enjoyed it. I want to say happy April at Sarcoidosis Awareness Month. It's still, of all, I love everyone, but it's still my most favorite passionate disease state that I want to be part of and be proactive with. And if you do want to talk to me or hang out with me or see what I'm up to, don't laugh at me. Someone's laughing. You could go to my social media and just say you enjoyed our talk or something. And if you like podcasts, this month I'm putting some people on who are sarcoid pros in our area over here. I just posted some about multiple sclerosis. I always do things about disease state. My dad had Alzheimer's and my mom was the primary caregiver. My mom was on there. I interviewed her. So that was a really cool episode. So check out my podcast. And with that being said, Abby, I'm done on my side. I'm ready to take some questions.
Oh, thank you so much, Dr. Raj. It's so interesting. Yeah, just I interacted with oxygen with my baby when she was little, but it's so helpful. And I loved how you just walked from the very beginning to the very end. So thank you very much.
Oh, you're super
Um,
welcome.
so we have various questions, and what I'm going to do is I'm going to start with the questions that came in now, and then as far as we get, we'll go until we're done. So, okay. First question. Um,
Sure.
if I have sarcoidosis in my lungs, can it spread to other organs? And also, why am I always having shortness of breath when my oxygen levels are normal?
Great question. So, when I talk to sarcoid peeps, meaning you folks out there, you guys are so smart. You know what the answer is. If sarcoid is in one organ in the body, it's probably what? Yeah, it's probably somewhere else. But if it's somewhere else, the question is, what do you do with it? What do you do with it in your big toe? You know what I mean? So just because it's somewhere else, I don't always treat it. In classic organs are going to be the spleen, the liver, you know what I mean? The kidney, unless they're acting active symptoms, you know what I mean? And sometimes I don't even know it's there. So if you have sarcoid in the lungs, what a surprise, 90% plus patients have sarcoid in the lungs, and you're still short of breath, think of that diagram I put up there. Is it the heart? Are you anemic? Because you know what? If you put a pulse ox in someone with heart failure, it would be 100% because it's not bringing the oxygen in, it's delivering the oxygen. If you're anemic, your pulse ox will still be 100% because it's not bringing the oxygen in, it's having enough taxi cabs to deliver it. So then, of course, could it be something else? Should you check your thyroid? Are you and me, should we join a gym because I'm getting overweight? You know what I mean? So it really is the hardest thing ever, but I wouldn't brush off that. I know I'm very jovial, but if you're still short of breath and it's not the lungs, you got to do a search of what it is.
Hmm.
Great
Thank you.
question.
Yeah, that makes sense. Thank
Yeah.
you. Okay, next. I was placed on oxygen 3 months after my pulmonary diagnosis. Does
Mhm.
that mean it's advanced since I required oxygen so soon?
Great question. And I think the problem here is communicating with the team in the hospital before you got discharged. You know what I mean? It's so often when you're overworked and my residents have tons of people, I can't bring the computer in the room to show them the images of their CT scan or their chest x-ray or really explain what's going on. So I discharge tons of people on oxygen because there's a certain point you just don't want to be in the hospital. You're going to catch a hospital-acquired infection. And then sometimes it's just better to be home. And I love being home. But I would tell my patients, hey, it's an infection, but we're on the right track. It's your sarcoid. I initiated steroids, but it's going to get better. You know what I mean? So I don't just think the initial being discharged at home is going to be something to be overly worried about. But I would ask those questions. Why did you put me on it? And when do you want to follow up? And how are we going to follow up? And are you going to repeat the x-ray, repeat the CT? So I think all those is about communicating, but the statement you made in itself, just because you were sent home on oxygen doesn't mean poor prognosis.
Okay. Okay. Thank you. It's helpful.
Yeah.
Do sleep PAP machines help with oxygen?
Oh, see how I just threw that right answer in there? So the answer is if you have obstructive sleep apnea, don't get me wrong, apnea means no flow. Flow of what? Air. No oxygen in, no carbon dioxide out. So many people who stop breathing at night who have apneas, of course, their oxygen goes down. You know what I mean? So, but if I know that you have low oxygen at night, and I also know you have obstructive sleep apnea, I will treat the obstructive sleep apnea first. So so the wrong thing to do is, oh, you have obstructive sleep apnea? here's some oxygen. That's not how you do it. That's a good way to get sued, you know? So what you have to do is treat the obstructive apneas first and then decide if you still have low oxygen. And I have patients like that. So sometimes when I treat the obstructive sleep apnea with CPAP or a BPAP, yeah, their oxygen gets better. Sometimes because they have underlying disease like COPD or sarcoid or pulmonary fibrosis, they need to treat the sleep apnea and on top of that, have supplemental oxygen. So great question on that one. That was a great question. I mean, I got to tell you, they're all great so far.
Yes, yes. It's so, I tell you, sarcoidosis patients, they know their stuff.
Yeah, they know their stuff, dude.
They know their stuff. Okay. Would a PFT also help determine if home oxygen is needed?
Oh, great. So a PFT in itself doesn't qualify you for home oxygen. You know what I mean? Once again, how do you qualify for home oxygen, everyone? Pulse ox, arterial blood gas. That's how you qualify. You know what I mean? Now, PFT just tells me if you have lung involvement, how are your lungs doing? And that's why I tell my sarcoid patients who have lung involvement, well, because you walked in here and you look okay and the exam was good, I could tell you just based on guessing, yeah, your lungs are okay. But if you want to be objective, then I need to do parts of a pulmonary function test to give you a number. Uh-oh, this value decreased by a certain amount. But I will say this, when we talk about qualifying for pulmonary rehab, they might require you to do a PFT to qualify for pulmonary rehab, or they'll only accept people who have a certain cutoff. So that is a good pearl for everyone. You may need a PFT to qualify for pulmonary rehab.
Okay.
Yeah.
Thank you. Okay, next question. Isn't it expected to be more short of breath when exercising when you have sarcoidosis?
And I would say not just sarcoidosis, I would say just in general, you know what I mean? I was running late for this conference. I ran up a couple flights of stairs, a little winded, I gotta tell you. So, I think when you are exerting yourself, of course you should be more short of breath. But yes, if you're a sarcoid patient who has cardiac involvement, who has side effects from steroids, you're just gaining weight, or some lung involvement, or you're anemic from sarcoid or not, you know, it is expected to an extent that exertion is going to give you more of that feeling of shortness of breath, but I don't want to mislead anyone. You know what I mean? If suddenly you've changed where you're doing your routines, your activities of daily living, you're going to the gym, and then a month later, you're only doing half of that, that's not normal. And that's where you can laugh at me, the diary. I think it's so important to write down when there's changes in your health, whether you're on home oxygen or not, to get a workup. So the answer is it is expected to be more short breath when you're working, but just don't take it for granted that it's just normal. There's a point where it's outside that normal range, needs to be worked out.
Yeah, yeah, that makes sense. And along that lines, that's what the sarcoidosis planner is set up to be, is a way that you can track, like, yes, there's a section that tracks your habits and then your symptoms and how those are interacting. And so I'll put the link in the thing, but
Yeah.
whenever you're talking about journaling, really that's what it is. It's a sarcoidosis journal plus.
That's
So
awesome, dude. I
yeah,
love it.
yeah,
Journal
yeah.
Plus. I dig it,
Yep. Yep, yep. Thank you. Thank you for clarifying.
Yeah.
What do you think about over-the-counter oxygen boost when you don't need ongoing oxygen tanks?
You know what she's talking about? Have you heard these, Abby, before?
Yes. Oh, I live
Yeah.
in Colorado. Oh,
Oh,
yes.
they're like little canisters, right?
Yeah,
And
yeah.
you can buy.
They're like in our gas stations
Oh
here
God,
because
really?
you go up to 14, you do a 14er
Yeah.
or, like all these mountains and so yeah, they're like oxygen booster in all of our gas stations.
I'm a little naive, but I found out that one of my patients, you know what I mean, who was a really well-to-do, kind of thought A game type person, was feeling short of breath. And he called me, said, "Hey, Raj, Dr. Raj, whatever." He's like, "I'm feeling more short of breath. And every time I take my oxygen boost, it's not helping." I'm like, "Oxygen boost? I didn't prescribe oxygen." He's like, he showed me these canisters that he was taking. So the answer is if you're symptomatic, get it worked up. Get that x-ray, figure it out. I'm not a big fan of these oxygen boosters, and it scares me because some of them come in flavors, and oxygen is not supposed to be flavored. It's freaking me out a little bit,
I
so be
didn't know
careful.
that.
Yeah,
Oh, so if I don't know if you're a football person,
I know my football.
anybody that's football people, if you watch the games that they do in Denver, all the players will be on the sideline with those oxygen.
Yes.
So interesting. So interesting. I know we are out of time. Are you on a hard deadline? Do you want me to ask some more? What is your
Why don't you do two or three more?
two or three more?
And before I go, I just want to at least verbally say hello to Janice Miller. She's been like raising her hand left and right. And I just want to tell her I say hi,
She
I'm
is
not blind.
engaged.
And if I don't get to her question, can you just tell her that it seems like you're one of my biggest fans because no one else wanted to talk to me as
Oh,
much as her. But
oh.
give me three more
Well,
questions and I'll
we
go.
have a question. I won't say it's hers because I can't say it's hers.
Okay. Yeah.
Um, okay. Um, I have sarcoidosis and I'm diagnosed with asthma. How do I know what is causing my breathing issues?
Yeah, it's a great question. So, sarcoid can mimic asthma and vice versa. And I have many patients. And, the answer is you can never tell because I have patients that have both. Asthma is very common. I'm going to give a number. I think it's 23 to 26 million people in the United States have asthma, including kids and everyone.
Mhm.
Common things are common, you know what I mean? And sarcoid can wheeze, sarcoid can get chest pressure. And I think sometimes there is an overlap because when I treat an asthma exacerbation, it's going to really be centered around steroids, both inhaled and oral. So I could get a TUFI, which is a 2-for-1, but sometimes I may need to get a CT to see what's happening in the lung. I may have to get inflammatory markers, but it's really hard to discern. So great question. I've always guessed wrong, but most of the time I treat for both.
Hmm. Hmm.
Yep.
That makes
Good
sense. That makes
question.
sense.
Yeah.
Okay, can you talk about this patient is saying when they're only short of breath when they're outside walking around, moving around. So how would a stationary tank at home help in that situation?
Great question. So it's not, you know what I mean? Because, if the first thing is, talking to the DME and your provider. What do you want to accomplish? Is it going to the garden? Is it going to see the grandkids? Is it going to the movie theater? Because it's going to be distance from home, time away from home, and how much liter flow you're going to be on. So if you have a stationary machine, that's only a 50-foot cord. That's to be at home. You know what I mean? So you need to ask your provider, if my liter flow is only 2 liters, maybe 3, maybe 4, you put an oxidizer on me. Can I get it down a little bit where I can go out? And how far can I go with an oxygen concentrator that makes it? Or what kind of tank can you carry? The most common tank we carry are called E-cylinder tanks. And if you go an E-cylinder tank for 2 liters, you probably can get 3-4 hours out of it. You know what I mean? So I think it's really preparing. It's not easy. You know what I mean? Or maybe if you could be qualified for that oxygen conserving device, all these things, you know what I mean, have to be discussed. So I think that see if there are options for you.
Yeah, yeah. No, that's really helpful to think about. Thank you.
Yeah,
It's
one
so
more. One.
interesting,
I
just
know.
like listening to all of this. It does give me so much more appreciation when I see people with oxygen. Like,
Oh
there's a
yeah.
lot that they are dealing with.
And
So,
and
yeah,
that's why I always kind of lecture my med students in a nice way. The answer is, yeah, give them oxygen. I'm like, yeah, you're right. That's the answer on the boards, but it's life changing, man. You know what I mean? How'd
Mhm.
you like to be a 50-foot cord tethered here? I mean,
Yeah,
you need it, but you got to be empathetic about it, and it's not easy.
yeah,
Oh, by the
yeah.
way, abs. So has this been unique have you had a conference like this in a while? Has this been a little different theme finally? You know what I mean,
Yes, yeah,
guys?
no, this is really great. And we've
Cool.
had a
I'm
lot
really
of
liking
people
this,
asking
dude.
for oxygen. Like,
Cool.
just quite a few people, yeah, recently have been interacting with it. And so
I'm
this is
glad
so
we did
helpful.
this,
Yeah,
dude.
yeah.
Okay, give me
Okay,
one
do you
more. Give
have
me
like
one
a
more.
few minutes for
Yeah.
some non-oxygen questions? I know
Oh,
you
all
said you
right.
were open to that.
Okay.
I know, and everybody, there's so many questions, and I'm so thankful. If we don't get to your question, you can email me at abigail@lifeandbreath.org, and then I will reach out and get your question answered from an expert. So please email me your questions if we don't get to them tonight. Okay. We have a couple that came on and add just half
Mhm.
totally sarcoidosis questions. Is sarcoidosis hereditary?
Wow, love it, love it. So the answer is there are going to be some genes that are associated with sarcoid. Now, is it the classic thing we memorized in med school where it's an autosomal dominant or recessive. No, it's not like that at all. But I mean, one of my patients who followed me from my old hospital to my new hospital, I love him so much. His dad had sarcoid, you know what I mean? So, and I definitely see it in my patients. So I think that what is the take-home message? There's some kind of trigger that causes sarcoid. We don't know what it is, but you got to be genetically predisposed. And I do feel that if you
Yes.
told me that a first-degree relative has it, I can't prove it, but you're going to be at a higher risk of that. But there are some genes that are associated with it, but we do not order genetic testing for sarcoid. Great question.
And I know we're working with a doctor in Sweden who's doing a bunch of genetic testing. It's
Yeah,
very
there you
interesting,
go.
but she doesn't have results yet. But she's very excited. She wants to speak once she finishes.
Of
So,
course, of course.
okay, can you talk about methotrexate? The question is, can methotrexate help with sarcoidosis?
You know, methotrexate was one of the old school drugs when, even before I was born, that we were using to treat sarcoid. It's a drug that we stole from people who were getting cancer. We stole it from the rheumatologist for RA. And it used to be my go-to, what I call DMARD, disease-modifying antirheumatic drug. So usually I would start methotrexate, if we're unable to taper you off oral steroids like prednisone. But this new generation, kids are getting so young, and doctors, you know what I mean? You go to your doctor like, oh my God, how are you a doctor? Like what they're doing nowadays is the minute we start prednisone, they may start a methotrexate-like drug right away because they're like, we want to make sure that we can taper off the steroid as quickly as possible, and they won't even give the chance of just giving the steroid by itself. And that's not wrong. But I'm going to tell you, I'm going to give you one of my little pearls today. You know what I mean? I use a lot of methotrexate, don't get me wrong. You have to pick the right people. It's toxic to the liver. You got to take folic acid every day. You do take it once a week. You know what I mean? You can have hepatitis B or C. There's all these things. But my new thing I'm kind of using as my alternative to methotrexate is something called mycophenolate. Mycophenolate goes by the brand name Cellcept. And it just lately, all these youngins that I'm part of all these sarcoid multidisciplinary meetings, they kind of convinced me that mycophenolate is a good alternative in some cases. You take it twice a day. It really works on lymphocytes. It doesn't have lung toxicity that methotrexate might have. It doesn't have liver toxicity as much as methotrexate, but we don't have as much data. So methotrexate is been used for so long that we have so much confidence in it. It's not wrong to be on it. I still use it, but that's my little pearl that I think that my alternative, if I have a patient who's not doing well on methotrexate, I'm using a lot of mycophenolate lately.
Oh, that's really
Yep.
good.
Yep.
Well, I tell you, Dr. Raj, I think we need to do another Q&A with you sometime because there are so many questions that are
That's
coming
cool,
in.
dude. Just everyone, I love each and every one of you. I really do mean it, or I wouldn't come on here after work. And yeah, reach out on social medias, and I'll try to come back and hang with you guys again.
Oh, thank you. Thank you so much. And thank you everybody for spending time with us this Thursday
Thank
night.
you, everyone. I love everyone.